So thank you so much for all the presenters and the panels. And now we'd like to open for the discussions for up to 12:40, and we have quite a good time. So please, first, I think we'd like to invite the audience for any questions or the clarifications or the comments for all the panelists and also for the community, the representatives.
One at a time, please.
Okay, so on the left, please.
Yes, this is Roger Kuyas from Zurich. I have a question to the last talk. Thanks, Julia, for this very interesting talk. And to the non-expert, it at least seems, but I think it's the case, that the human rights situation for migrants in Europe has worsened significantly over the last years, at least, with what politicians say they want to do, and they steepen up actions against migrants and so forth. To what extent has this had already effects on the HIV and STI epidemics among migrants?
Thank you, Roger. Well, it's very hard to capture that exposure variable you are describing into and see if that has had a direct impact. Of course, it could impact negatively many different aspects that we've explored in the surveillance data and in the cohort data. And we were particularly concerned if this anti-migration trend or epidemic in Europe has made migrants to be less likely to test for HIV. Therefore, we could observe higher rates of delayed HIV diagnosis. This so far we have not seen, and we've looked in detail. So this is probably good news of the resilience of the HIV community that has been fighting adversity for a long, long time, and how migrant-friendly many HIV testing sites are, in spite of the very, very well-thought comments Esther had made on the discrimination of healthcare providers in general. But I think the HIV testing community has been very close to the needs of the undocumented migrant communities. We've not seen in the big figures any evidence that this anti-migration trend in Europe is impacting on HIV testing patterns. But certainly there are reports from publications, from clinicians we work with, that people are more fearful to come forward, and we're making the lives a lot more miserable. I don't know if Esther, I'm sure Esther has more community insight.
Yeah, I mean, this has a really large impact on late diagnosis as well, which is very difficult for not only the individual, but has an impact on the health systems as well.
Yes, of course, migrants have higher rates of late diagnosis than non-migrants, that's true, but we've not seen increases of that proportion over time. Not yet, but let's make sure it doesn't happen.
Thank you.
Thank you. So maybe the first microphone, ladies, please, and then the next in the back.
Thank you. I'm Elske Hornenborg from Amsterdam, the Amsterdam STI Clinic. And I've a question to Tonia and Abheena. Our clinic is open for transgender people, but up to now we found that not very many people find their ways into our clinic. Do you have some remarks or suggestions how we can make our STI clinic more trans-friendly? And then, if I'm allowed, a second question to Julia and Esther. In the Netherlands, when you are a migrant from the European Union, even if you have insurance from back home or you don't have any insurance, healthcare and ART is not available. It's available when you're uninsured and from Southern Africa, but not when you're from Europe. Is that something that is known from other European countries as well? And do you have some suggestions for that?
I just want to thank you for that question. I have a short answer and a long answer, but for the long answer, I'll refer you to some resources. The Center of Excellence for Transgender Health has a website that you can Google, and they have an entire training program, as does the National LGBT Health Education Program. But in the short term, I would say engage community leaders, thought leaders from the trans community into your program, and they can see things that often are invisible to you that might be barriers. And so engaging the trans community and helping you understand in your local context what helps make the site more friendly would be really helpful.
Thanks, Tonia. I'll just add to that. One thing that we are doing in India, and we are trying to do it across the globe, like in UK and other things, that we are not, when it comes to HIV and STI, those are probably not be the priority of transgender people at this point of time. Their priorities are, at this point of time, about gender transition. Their priorities are much more about education, employment, and other related aspects. So health becomes like third or fourth or fifth, sixth priority for them. What we are trying to do is that we are creating a gender lab for transgender people, which is more comprehensive lab. Not only talk about STI, but address these immediate needs that they need, and that is what is helping for people to come ahead and access the services. The other thing that what we are doing is that we have trained bunch of transgender people to provide basic counseling support on STI, and that has increased the faith among the transgender people to access these clinics, because they know that they will be seeing people like them who are providing services at the healthcare centers. So probably you can help it. If you need more help, we are always available for it. Thank you so much.
Thank you. Esther and I were discussing that there are differences across the different countries, but in general, one member state will charge the other member state for what that member state is costing us. That's the agreement. And we don't see differences in access to healthcare for Western European migrants, probably because of that. When you look at the ECDC data, the proportion of migrants testing late doesn't differ from native populations to those coming from other Western European countries because of the entitlement issues.
Elske, is that true for the Netherlands? Do we charge other European countries for the ARVs? Because apparently we don't, because we have this problem that you just described.
I'm not sure if Andrew wants to cover that, because there are differences between countries, but that's certainly the case in Spain. We would charge the Netherlands for what cost. Yeah.
Is it a comment on this issue? Yes.
Yeah. The arrangement is mainly for emergency services, the blue card. But if you're living in the country and working in the country, then there's a different entitlement system. And not everyone has it figured out the same way.
Yeah.
At the back was first, Lorraine after.
Kyle Bernstein, US CDC. My question is for all the panelists. Most of the data that's presented for key populations really focuses on numerators, which is easier to obtain, but doesn't really give the audience a sense of what the disparities are between different populations at risk. And I was wondering if anyone could talk a little bit about efforts to enumerate the populations that you work with.
I'll take the plunge, right? So it's a challenge depending on which key population you're talking about, and it sounds like you work for the Centers for Disease Control and Prevention, so you know some of the challenges of building trust in communities so that people are willing to come forward, and also for identities that might change over time. people have a period of time where they come out and self-identify along, or may never identify along the categories that we choose to put them into. So I think that's going to be an ongoing challenge. But there is a lot of really great work that's happening to enumerate populations locally. I know in the United States, the Williams Institute has long published data based on the BRFSS, a Behavioral Risk Factor Surveillance Survey, that gives us population-based estimates of the number of trans people. And there are also other countries that are asking questions about gender identity in their national population survey. So I think we're going to see more of that for trans populations.
Yeah, I think one of the challenges is that besides the fluidity of people's sexual identities and the fact that levels of behavior may change over time, so perforce many of these samples are snapshots of what's a moving film, but you also have the dissonance between identity, attraction, and behavior, and knowing all three are relevant to be able to form programs and education and training providers, but they will give you different denominators. So I think one has to also be quite contextually specific whether the question is it a denominator of people at risk for acquiring or transmitting a specific infection versus a community where sometimes broader-based education may help reach the people who may be at greatest risk. So I think you need all three kinds of behavior, even in terms of even attraction is important to know.
And regarding migrants, apparently this is the hardest thing to do, to be able to capture migrant stocks and flows, and we've been trying to look at those numbers in the European statistics, in fact, to understand some of these trends. It would be very interesting to know if the declines in number of HIV reports coming from sub-Saharan Africa is reflecting a lower number of migrants altogether of only those with HIV. So it's very, very challenging, and when we were addressing that, I came into a document by UN Statistics Office that said one of the toughest things we do is identifying and estimating migrant stocks and flows. So I really think the UN office should work as hard as possible, because we really need those numbers to understand what's going on.
Thank you. We'll take Lorraine first, then the gentleman at the back, and then the lady on the left.
Thank you. I was very interested in the findings that seem to be gathering pace, that migrants, for the most part, are actually acquiring their infection post-migration. And I wondered whether anyone's dug into that. Is it traditional risk that is just found in this group, or is the migration somehow exacerbating or changing? Is there something very particular about being a migrant that's a new a risk that we don't maybe fully understand? So my questions coming out of that is, first of all, is there any specific interventions for this particular group? And is there any data on the length of time they've been a migrant before they acquired it? So are these new migrants caught up in the moments of real challenge, or are these migrants who've just integrated into a new community and then just live with the general well-known kinds of risks?
Thank you. You've asked many questions at the same time. It's really, even if it looks surprising that the proportion of post-migration acquisition is so high, some colleagues in London had been seeing that for quite some time. And it really makes sense that when people migrate and the community enlarge and they have friendships and sexual partners within the community, it makes sense that post-migration transmission also takes place. Again, heterogeneity is a key aspect to take into account. What happens with migrants from sub-Saharan Africa and heterosexually transmitted epidemics, totally different from what happens with migrant MSM who come to Barcelona, Madrid, or London, really escaping a lot of the homophobia in countries of origin. So whether they do more and they take more risk after they migrate, or they take the same risks but they are in a higher HIV or STI prevalent setting, and because they're more vulnerable and more lonely and they have less access to testing and prevention. So lots of different factors go on. But the fact that 72% of the migrant MSM in Europe have acquired HIV post-migration really identifies them as a group really for PrEP. It's insane that there are many countries in Europe that are not providing PrEP. For the migrant MSM group, this is a priority.
Hi, this is Pichtika from the Thai Red Cross AIDS Research Center. First of all, thank you for that amazing presentation. In Dr. Mayer's presentation, it says that the online platform gives the wider audience to have access to sex, and they're more likely to be infected with STI and HIV. So I'm wondering, especially for the key populations in all the presentations, what are the age ranges that these data are presenting? Because I'm really interested in especially young people. I'm wondering if they would behave differently than what we see, because I think the young people would have more challenges to have, first of all, access to the services and PrEP, for instance, with parental consent. So I'm wondering if you have any data on the young populations and if they behave differently than what we see right now. Thank you.
Yeah, certainly within the key population, I think you make an excellent point that young people are particularly vulnerable, and certainly rates of incident infections are tend to be higher, and certainly with regard to HIV in the U.S., for example, that's certainly the population we're seeing the greatest growth. So your point's really well taken that as we talk about the populations, we should also do secondary analyses to aggregate for age. And some of the programs we develop need to be more culturally specific. And one of the things that was implicit, but maybe should be more explicit about when I was talking about people using cell phones and using various apps, that's going to be, there'll be an age differential too. Not that older people aren't on Grindr, but the fact is that younger people growing up in an era of using phones, it being normative, that's an opportunity for meeting new partners. It's also an opportunity for more tailored education, interventions, triage to care more efficiently through electronic media.
Anyone else from the panel wants to? Please.
Hi, everyone. Thank you for presenting. And I just had a comment on more of the structure of this session. And more so, it was that, like, when I saw the outline, using key populations solely as the commenters, they are not on the sidelines, they are the experts. And there are many, many community organizations, as Abheena said, that are doing research, data, really in the front lines. And I think it is really important to show that and necessary. And especially as we begin a week, I urge you to use more truly inclusive terminology, wording, and session use. So thanks.
Thank you for that.
I also have a comment, because here we have a group of experts. We heard.
We can't hear you.
Can you speak to the microphone, please?
Yes. I also have a comment. So here we have a panel of experts, and we also talk about research done in settings by different organizations, NGOs, and so on. And it's obviously, if you look at all maps were presented, we don't have enough information, so it's very limited. And taking into account that everything is ongoing much is ongoing in the settings which experience the lack of funding, the lack of communication, the lack of political will, whatever. So maybe it's actually just a comment to the organizers that maybe we have to think about, I don't know, like an Amsterdam Code or something like this, or on a concept that some kind of initiative which would, let's put me bluntly, force or just promote institutions or research agencies which work on that area to collaborate more with partners on place. So just to think about it, because otherwise it just it's waste of resources. Thank you.
I think it's an excellent comment, and I think that also makes a point of the fact that we have actually divided this session into very clear groups of key populations. Well, we see from the presentations that actually they're very intertwined, and we have sex workers that use drugs, and we have MSM that are sex workers, and migrants who are MSM or sex workers and use drugs. So this actually has been a very rigid division, and we have to think through how we can reflect the interweaving of them in the next future. But anyone else wants to comment as well?
Well, I just want to agree and to thank EATG, Esther, Alain Volnian, and all the colleagues that we've been working together. In fact, the AMAZE study is an example of collaboration at equal level between community and kind of formal researchers. We cannot do without each other, so we really are a team.
All right, thank you so much. So we'd like to take the last comments.
Yeah, last comment. Francisco C. I'm the editor of Age Education Prevention. There's a special issue for the members who are attending the conference. Just go online, Age Education Prevention, and entire issue on HIV prevention, free access. The second comment is about transgender research. So when I was working at NIH, we have a strategic plan, and one of the priority areas is more funding for transgender research. But I don't know, under the present administration is very conservative. I'm not sure if funding is being provided. But during my time, I know that we have a high priority for it. Thank you.
Thank you for that. So,
it's time. Thank you very much for your contribution. Thanks to the panelists, the speakers. It's been very illuminating, wonderful, and see you after the lunch. Thank you.